Okay, welcome to my podcast on non-depolarizing neuromuscular blocking drugs, or they're also called non-depolarizing neuromuscular blocking agents. And they belong to the two categories. First is benzyl isoquinoliniums, and then aminosteroids. So when we start discussing these drugs, first thing we need to know is how these drugs actually work. What is their mechanism of action? For any drug to work, drugs should have a site of action, and most of the drugs have receptors. So this class of the drugs has a receptor called, I'll write it down here, nicotinic receptor. So these drugs act on nicotinic receptors. But as you know that there are plenty of subtypes of subtypes of nicotinic receptors in human body. You have nicotinic receptors in your autonomic ganglia, and also the nicotinic receptors in central nervous system, and there are nicotinic receptors on neuromuscular end plate. So these are the receptors that are targets of our neuromuscular blockers. So I will write here nicotinic receptors at a neuromuscular junction, at the neuromuscular junction. You can also call it as a motor end plate, motor end plate. So these drugs actually work on a motor end plate or nicotinic receptors. These nicotinic receptors are sometimes referred to as NM subtype receptors. So what are these receptors? A nicotinic receptor on a neuromuscular end plate actually is a cation channel. I will just draw it to simplify what it looks like. So this is an oversimplification. So let's say that this is a hypothetical ion channel. Shape it like a tunnel. So this is an ion channel, and through this ion channel the cation can pass. Let's say a cation is a positively charged ion. They can pass through this channel. So this is a nicotinic receptor, more or less. So nicotinic receptor actually has 5 subunits. First of all, the most important subunits are, let's say here, actually I can use this tool. Yeah, there are 2 subunits. They're called alpha subunits. So let's call them alpha subunits. Then there are 3 subunits called beta, delta, and epsilon. So let's say this is a beta subunit. Let's call it beta. And then you have delta subunit. Let's make delta as gray. So this is a delta subunit. And then let's make a last subunit as orange. It's called epsilon. So you can see there are 2 alpha units, 1 beta subunit, 1 delta subunit, and 1 epsilon subunit. So this is a nicotinic receptor. I will just say this is a typical nicotinic receptor on the motor end plate, the receptor we will talk about. Okay. Now this is, if I go into a little bit more detail, this is adult subtype of the nicotinic receptor on the motor end plate. You can have a modification of this receptor, which is called fetal nicotinic receptor. I can say there will be a modification, I'll write in the brackets, close brackets here. You can have another subtype called fetal nicotinic receptor. The difference is here, the epsilon is replaced by a slightly different subunit called gamma subunit. And these receptors also are cation channels, but they behave differently. We'll talk about that um, in another lecture. Okay, so for simplicity, we will talk about nicotinic receptors found on the motor end plate that consists of the 5 subunits. Now let's say a drug in the question. Let's call it D. So D is a drug. I'll make 2 D's here. D is a drug which is non-depolarizing neuromuscular blocker. So they actually attach on our nicotinic receptors. So 2 molecules of the drug attach on 2 sites on the nicotinic receptor. That's 2 alpha subunits. So both alpha subunits bind to 2 drug molecules, and then this channel opens up. And this channel opens up and allows the cations from extracellular space to go intracellularly. So I would just draw it again. Okay, so this is our ion channel, and let's say this is our lipid layer, cell membrane. So when the drug attaches to the alpha subunit, the channel opens up. So a lot of your, let me change this. So a lot of your positively charged ions that are cations enter from, oh, something happening here. Okay. So a lot of your positively charged ions from extracellular space enter into intracellular space. These ions can be sodium ions, or also you can have potassium or calcium. So the nicotinic receptor is actually a cation ion gate, which is permeable to sodium, potassium, calcium, and majority of cations. So, so what we discussed so far? So we discussed so far that the drug that is the non-depolarizing neuromuscular blocker, we can call it NMB, attaches to the nicotinic receptor that is the the alpha subunit of the nicotinic receptor. Let's say nicotinic here. And then what happens is it opens up. The nicotinic receptor opens up, and then this allows influx of cations into the cell, which in this case is skeletal muscle. Skeletal muscle cell. So one thing very important I wish to highlight here, the receptors we are talking about, these nicotinic receptors, they are present on a motor end plate of skeletal muscles, not on the smooth muscle, not on the cardiac muscle. So we are specifically talking about the nicotinic receptors on the motor end plate of a skeletal or voluntary muscles. And these are the muscles that get relaxed by our neuromuscular blockers. So neuromuscular blockers, they do not have any effect on smooth muscles or cardiac muscles. So I will just again highlight this. So neuromuscular blocking drugs, they act on skeletal muscles only, skeletal muscles. And needless to say, not on the smooth muscle, not on the smooth muscle, not on the cardiac muscle. Okay. And the motor end plate we are talking about is skeletal muscle motor end plate. Okay, next slide then. What does a motor end plate look like? So hypothetically, you have this small nerve terminal that has a lot of acetylcholine vesicles, as you know from your physiology classes. And then let's draw here in brown your skeletal muscle motor end plate. So this is small part of your skeletal muscle. That is, everything is called, this whole thing is called motor end plate. I'll just make it as a neuromuscular junction. This is a motor end plate. I'll label it as a motor end plate, which is postsynaptic. And I'll label this, as you know, nerve terminal. So apologize for my spelling mistakes. This is a nerve terminal. So at a neuromuscular junction, you have a nerve terminal in vicinity of the part of a muscle cell, motor end plate, and there's some space between the nerve membrane and the muscle membrane. So this space is, let's call it like, let's color it as green. So there's some space, as you can see, few micron space. They're not touching each other, but they are in the vicinity of each other. So this space, what is it called? Synaptic cleft. Synaptic cleft. So this is what I could draw. So you have a nerve terminal, motor end plate from a skeletal muscle, and a space called synaptic cleft. The whole thing is called neuromuscular junction. When the nerve terminal is depolarized and reaches an action potential, it releases a lot of acetylcholine into this synaptic cleft. Let's simplify this. And let's go to our original color. So this is your nerve terminal. This is your motor end plate. And this is your synaptic cleft. So when the nerve terminal, actually let's label it to prevent any confusion. So this is nerve terminal. Okay, this one. And this is, let's call it motor end plate. And let's call this space as synaptic cleft. So when nerve terminal is depolarized, it releases a lot of acetylcholine. That is acetylcholine, acetylcholine, acetylcholine from nerve terminal into the synaptic cleft. And this acetylcholine actually goes and attaches to our nicotinic receptors here. Let's call them nicotinic receptors. I'll just label it, and it's called nicotinic receptors. If you want to be lost in translation, I will also tell you nicotinic receptors are a subtype of acetylcholine receptors. So they can also be called as acetylcholine receptors, subtype nicotinic, subtype neuromuscular junction type receptors. So what happens is once this acetylcholine attaches to this nicotinic receptor, we know that the receptor opens up. This is a nicotinic receptor. Let's say this is nicotinic receptor. And once this acetylcholine attaches, This is acetylcholine, and we know it attaches to what? It attaches to the alpha subunit. So there's a lot of influx of the positively charged ions. Let's call it positively charged ions into the cell. So this positively charged ions influx results in something called end plate potential, EPP. EPP, but it's so small that it's called miniature, like tiny. So it's called MEPP. So on a hypothetical muscle membrane, if this is your muscle membrane, let's say this is your muscle cell membrane, there's a lot of EPPs generated because there are so many end plates and there's so many nerve terminals. So there are a lot of MEPPs generated. So all these miniature end plate potentials actually add up, and then this becomes something called big EPP, end plate potential. And then this causes, the next slide I'll show you, all these MEPPs, MEPP summate, they add up. That is summation sign. And they result in what we call it big end plate potential. That results in opening up of now voltage gated sodium channel. Voltage gated sodium channel. And then, because of the opening of voltage gated sodium channels, now we have depolarization. So we have a depolarization, and then we have action potential, and we have contraction of the muscle. So you see that the most important thing, small miniature end plate potentials, because of binding of acetylcholine to nicotinic receptors, result in end plate potential that causes opening up of voltage gated sodium channels subsequently, and then that causes a depolarization, and then what we call it EP coupling. That is, sorry, coupling, that's my spelling mistake. That's called excitation, contraction, coupling. Actually, let's say it's called, let's make it right. It's called excitation, contraction, coupling. So coming back to the drugs now. So how do the nicotinic receptors work? We understand that. Now how do the drugs work? The non-depolarizing neuromuscular blocking agents. How do they work? So if this is your nicotinic receptor, just let's assume that this is tunnel is your nicotinic receptor. And these are your two alpha subunits. And we know that they have a binding sites for acetylcholine here. And let's say our drug is called D. So our drug actually competes with acetylcholine to bind on these alpha subunits of acetylcholine receptor. So D is simultaneously attacking the nicotinic receptor, that's called nicotinic receptor, and competing with acetylcholine to bind to the receptor. So what our drugs are, the drugs in consideration, they are competitive antagonists, right? Because they're competing. They're competitive antagonists of acetylcholine for nicotinic neuromuscular junction type receptors. Sorry, my spelling mistakes. Neuromuscular type nicotinic receptors. Again, sorry, you know what I'm talking about, so I hope that's okay. So you can see that the drugs are fighting with or competing with acetylcholine to bind to a nicotinic receptor. So they are competitive. Why they are antagonists? Because binding of the drug to the receptor does not result in a clinical response. So if acetylcholine would result in the entry of cations into the cell or opening up of a nicotinic channel, that's a response. The binding of D, that's drug, to the nicotinic receptor would not result in opening of the nicotinic channel. So they will bind, but they will not produce any response. So they are called competitive antagonists of acetylcholine for NM receptors. That means that all of the pharmacokinetics of competitive block apply to these drugs. So if we have a receptor here called R, and it is simultaneously being attacked by acetylcholine and also our wonderful drugs, they are competing. Which one wins? What do you think? Which one would win? Of course, there is some tiny details like receptor affinity and charge and all that. But for a simplicity, what we have is a law of mass action or democracy. So if you have number of D more than number of acetylcholine, D wins. If you have number of acetylcholine more than D, then acetylcholine wins. So it depends on the concentration at the neuromuscular junction. So that's oversimplification, but on most part that should work for clinicians. So let's say I'm gonna just highlight here. So binding is directly proportional to the number of drug molecules available. There's another way to highlight it. Let's say you put acetylcholine here. Let's say you put drug here. What binds to the receptor depends on which one is in a higher concentration or higher amount. So balance can be tilted. If I put some more drug here, balance would be tilted like this. If I put some more acetylcholine here, this balance would be tilted like this. So that is one proposed mechanism of action. So these non-depolarizing muscle relaxants also have other actions on the neuromuscular junction. So supposedly or potentially, if this is a nicotinic receptor, these drug molecules, let's say D, they can also physically go in this hole of the receptor and block it. That's one of the proposed mechanism of action. Additional um, mechanism. We all know that they act by competitive antagonism, but they might also have this effect too. That's physical blockage of the, that's called physical blockage. Actually, the blockade would be different. Physical blockage of the channel. And then there's also another action. So we know that there are acetylcholine receptors on the muscle end plate. But there are also the preganglionic nicotinic receptors on the nerve terminal itself that result in the feedback, positive feedback. So when the acetylcholine is released from the nerve terminal, it can positively increase its own release through a positive feedback from these prejunctional receptors. So our drugs also can go and block these prejunctional receptors. They can also block prejunctional nicotinic receptors. So it's three things. For the most part, it's competitive antagonism, then blocks the prejunctional nicotinic receptors, and also can physically obstruct or block the channel. The next thing is we will discuss about the classification of these receptors, of these drugs. So you can classify the non-depolarizing neuromuscular blockers based on two different criteria. One is the chemical structure. So either you can have benzyl isoquinolinum compounds. The example is Atracurium, then isomer of Atracurium, that's called cis-Atracurium, then something called Mevacurium, sparingly used in United States, widely available in the United Kingdom. And just for completeness sake, I will say Rocuronium, not clinically used, but has a historical significance. Then you have a second class, which is called aminosteroid. For example, you will have Rocuronium, widely available everywhere, and Vacuronium. So between these two, I have seen mostly people using Rocuronium in the operating room or Atracurium. I've seen sometimes cis-Atracurium being used and Vacuronium being used. And very rarely I've seen Mevacurium being used. So the clinically most important drugs are Rocuronium and Atracurium. Someone might use this fancy drug, Atracurium, for reasons I will tell you later. Okay. Or I would say there's another way to classify these drugs. So you can have a short-acting drugs, they last for like less than 15 minutes, like Rocuronium, although you'll question the half-life of Rocuronium if you use it clinically every day. You will have intermediate acting muscle relaxants. Most of the clinically used muscle relaxants fall in this category, and they are Rocuronium. I'm using the abbreviations: Atracurium, Atracurium, Rocuronium. So, on most part, what we use is an intermediate acting muscle relaxants. Can't go wrong with them. So, now I'll come to certain general characteristics of these drugs. Uh, some of the disease conditions or physiological conditions, such as pregnancy or even drugs, prolong the action of non-depolarizing muscle relaxants. So this is a question often asked in different boards in different countries. Someone might ask you, okay, what potentiates the action of a non-depolarizing muscle relaxant, Atracurium? So you need to know this for that reasons and also for our clinical practice. So I will say the drugs. First of all, volatile anesthetics. We know what they are. Sevoflurane, desflurane. What they do, they prolong the action because they have a depressant effect on the neuromuscular junction and neurons. So obviously they prolong the action of the neuromuscular blockers. Sometimes you also need less dose. If you already have practiced clinically or seen these drugs being given, you'll see sometimes we don't even need the neuromuscular blockers if you're giving high doses of volatile anesthetics. I mean, they would not do the exactly same pharmacological um, I would say they would not give the same pharmacological advantage as neuromuscular blocking drugs, but they certainly will help to keep the patient immobile. So anyways, they potentiate the action. Second thing quite often asked is aminoglycosides. Glycosides. They also prolong the action because they decrease the acetylcholine release from the presynaptic terminal. Then you will have lithium also prolongs the action. Calcium channel blockers also prolong the action because they reduce the calcium influx into the cell, which actually is responsible for excitation, contraction, coupling. Then local anesthetics also prolong the effect. So, so you can see that these drugs prolong the effect. Someone might say that about the local anesthetic, someone might say that very low doses can have a different effect, can have a variable effect. But high doses usually prolong the effect. So next thing, we have some physiological conditions such as hypothermia. Hypothermia, as we know, prolongs the effect because it slows down everything. Acidemia or acidosis can also prolong the effect. And you can have hypermagnesemia also prolongs the effect, especially when you are giving magnesium in pregnancy to preeclamptic women. It prolongs the effect of non-depolarizing muscle relaxants because it stabilizes the membrane and decreases the acetylcholine release. And then some of the drugs actually some of the drugs actually can shorten the duration of action of neuromuscular blocking drugs, non-depolarizing neuromuscular blockers. These drugs are like calcium and also anti-epileptics like carbamazepine, phenytoin, and they actually shorten the duration of action. Calcium has two positive charges. Yeah, calcium, carbamazepine, phenytoin, and levetiracetam. Can't spell that drug right. I apologize. It's called Keppra. That's a generic name. So, anyways, the anti-epileptics and calcium can shorten the duration of action of these drugs. Now, let's talk about the individual drugs. We covered them on the most part, the mechanism of action and the basic characteristics of these drugs. So I'm just going to talk a little bit about individual drugs. Atracurium. So few important things about atracurium. It's metabolized by something called a combination of ester hydrolysis, and also Hoffman elimination. It's called Hoffman elimination. So ester hydrolysis is hydrolysis in plasma and tissues by non-specific esterases. And Hoffman elimination is a temperature and pH dependent spontaneous degradation of atracurium in plasma. So if you increase the temperature, elimination increases. If you increase the pH, elimination increases. Decrease the temperature, elimination decreases. Decrease the pH, elimination decreases. So that's the important thing about atracurium. It's not dependent on any organ for the metabolism. So you can give atracurium safely in people who have kidney failure, liver failure, because it's not dependent on those organs for metabolism. And interesting thing that atracurium is has a many isomers. It's actually isomeric mixture, and it is an isomeric mixture of 10 isomers. So it has 10 isomers in an ampule. So something else about atracurium, often asked in exams, and you might see in the clinical practice, it can or it has a potential to release histamine. And histamine can cause all the histamine-like reactions such as rash, bronchospasm. Not very often seen in clinical practice, but it's good to know this. I've seen some people avoiding atracurium for asthmatic patients. I'm not aware of any large studies showing the exact incidence of histamine release, but certainly it's something you should take into account, at least for the exams. And let's recap atracurium. First is metabolism is with ester hydrolysis in tissues and plasma. And also Hoffman elimination. Might be spelling it wrong. Might be one Freddy F. Hoffman elimination. And something they might ask you is, There's a product of astrohydrolysis, which is called laudanosine, Laudo, laudanosine. Clinically insignificant, but they like to ask you in the exams. Laudanosine can actually have can cause seizures. In some, it has shown to produce some CNS effects in some animal studies, but clinically insignificant. In Hoffman elimination, they might ask you that increase in pH, that is making it serum more basic, increases the Hoffman elimination, increasing the temperature, increases the Hoffman elimination. Second thing about Atracurium is histamine release. And third thing, I'm not going to touch the doses because they are different in different books, so I don't want to put a number on how much Atracurium you should give. But it's an intermediate acting muscle relaxant, and usually you can give anywhere between, give you a range, 0.4 to 0.6 milligram by deciliter for intubation. And after that, you can give 5 to 10 milligram boluses to maintain the paralysis or relaxation. So this is about Atracurium. Let's talk about Rocuronium now. That's another important drug. Rocuronium. So a few salient features. Rocuronium is aminosteroid. It belongs to a different category than Atracurium. It's also an intermediate acting muscle relaxant. And the salient points and you should know about the Rocuronium are, it's not very potent drug. So you need to give a lot of Rocuronium. So because it's not that potent, so you give large doses. So if you give doses something like 0.8 to 1 milligram per kilogram, its onset of action is very fast. Fast, or whichever word you like, rapid onset of action. So you can achieve intubating conditions very quickly and might substitute rocuronium for succinylcholine for rapid sequence induction. So that's something you should know. Normal intubating doses, as I said, I really hate to mention those numbers, but you can say 0.6 milligram per kilogram. And if you increase the doses, time to achieve the optimal intubating conditions decreases. And if you give sufficiently high doses, approximately this, then you can use it for RSI instead of succinylcholine. And then metabolism, rocuronium is actually excreted unchanged in liver and in kidneys. There's some metabolite of rocuronium they have occasionally found, acetyl rocuronium, which has about 1/20th of potency of rocuronium, and it's clinically insignificant metabolite. So on most part, it's excreted unchanged in liver, through liver into the bile, and in kidneys. And various studies have found that the duration of action of rocuronium is actually increased in the liver and kidney impairment. So if you have a liver failure or a kidney injury or end-stage renal disease, it results in prolongation of the action of rocuronium. And that's because of alteration in pharmacokinetic parameters such as volume of distribution. or volume of distribution at steady state. I'm not going into details of that, but essentially you should know this for your boards. Also, it's aminosteroid, so it does not release histamine. But it can cause anaphylaxis, so any drug can cause anaphylactic reaction. The next drug we're going to talk is another aminosteroid called Rocuronium. Important things about Rocuronium is also an intermediate acting muscle relaxant, exactly same mechanism of action as any other drug. And they might ask you that something about Rocuronium, how it's eliminated, or um, what's the metabolism of Rocuronium like. So Rocuronium is metabolized in liver. Just remember that. So it's metabolized in liver, and the metabolites do have some action. They do have some neuromuscular blocking activity, and the metabolites are actually excreted in kidneys. So with kidney failure, you might have some prolongation of action of vecuronium because its active metabolite is not excreted with same efficiency.